Our next talk is on fetal cardiac abnormalities in the first trimester, and I think in terms of cardiac abnormalities, I find this is the one that's most difficult convincing people that it's possible to make these diagnoses. Thank you. And I did share, in a sense, the data from Iris's, Papagiorgio and Jehan Karim's data on this. And the evidence is there, saying that the detection rate is, the order of 74% on a large population studies. So what I want to try and do is maybe try and simplify things and say, okay, if it is that good, how can I do it when I go to work tomorrow morning? And I think when you look at scanning the fetal heart in the first trimester of pregnancy, there's one just key image which I demonstrated in the live scan today, is to show simply a 4-chamber view of heart and then update it and show a 3-vessel tracheal view. And for every sonographer that comes to work at our unit, they have to produce 100 of these before we're sort of happy that they're ready to go out in a screening context. So the point I'm making is it's a good exercise to do, because you could easily just take a 4-chamber view of heart, print the image, save it to file, and then go and take a 3-vessel tracheal view, print the image and save it to file. That's not the point. The point is that if you demonstrate a 4-chamber and you learn the maneuvering of the probe to get the V sign of the 3-vessel tracheal view, if you learn that skill and force yourself to do it, then you will become competent in distinguishing what's not normal. Because there's 2 ways of looking at things in screening hearts. The first step is recognizing that something's not normal. And that's the most important step. The second step is when something's not normal, is working out exactly what the abnormality is. But we're all obstetrician gynecologists. We're not cardiologists. So when I show you examples of abnormalities, which I will, of what's possible, at the end of the day, I'm not the one who's actually making these diagnoses. I like to think in my head, oh, I know what this is. But at the end of the day, sitting beside me is a pediatric cardiologist, and I learn an enormous amount of information from them over the years, because they teach, and you watch, and you listen how they counsel, and you ultimately get a good understanding. But it's taken me 30 years to sort of get to the point where I say, yeah, look, I think I can characterize most. But I still don't do that. I do it with a pediatric cardiologist. That's a very fundamental starting statement before I even get into talking about it. So our role as obstetricians, as I see fundamentally, is working out when the heart's not normal. And that is not that difficult in the first trimester. The second point is as Badar mentioned this morning, is the magnification is key, because the heart from apex to base measures 9 millimeters and about side to side across the AV valves, about 6 to 7 millimeters. That's actually the size of your little fingernail. It's the size of the heart at 12 to 13 weeks. But with current day technology, that's not a barrier anymore. And the second point is that color is absolutely instrumental in making diagnosis. I would argue almost, and please don't quote me on this, but I would say that looking at the outflow tracks on a 3-vessel tracheal view on 2D is almost a complete waste of time. You promise me you won't quote me on saying that? But it almost is a complete waste of time. So if looking, I know, well, I know, it's a way of teaching. So in a sense, it's looking with color that demonstrates the 3-vessel tracheal view. That's so powerful. So let me get into the talk, having just said that. Whoops, I think this may be the wrong talk. Well, it doesn't matter, I'm sure we'll be fine. All right, so I'm just going to give an overview, and I'm going to talk about anomalies that we always see, sometimes see, and never see. So this was the study of Iris, which made the point if you've got no protocol, your sensitivity is 13% in detecting cardiac malformation. But if you have a protocol of looking with a 4-chamber, outflow tracks with color Doppler, your sensitivity is 78%. That is so impressive. You have to believe it. So in 2025, we're in a position where we can identify the majority of major structural cardiac abnormalities. Now, why that becomes so important, and why in Australia women with cardiac abnormalities that were getting the exome result when they're 28 weeks, is because in scenarios where the diagnosis has not been made in the first trimester. So we do a cascade. We do it, in a sense, find a problem at 20 weeks in Australia. We offer a chromosomal micro, and we do an amniocentesis, get a result back at 22 weeks of gestation. Then a patient goes through a multidisciplinary review. Then she has a wide exome sequencing, and then she's 28 weeks of gestation by the time she gets the result. Because if you look at cardiac defects, in fact, single gene disorders are more common than microdeletions. And therefore, we're looking at cardiac abnormalities through a different lens and saying we really need to make these diagnoses. That's a very important picture, what I'm showing you there, and feel free to take a picture of it, because it tells you exactly what is the genetic causes of cardiac disease at any gestation. And I want you to look at it. 15% of fetal cardiac abnormalities are related to the trisomies. Only 5% of them are the microdeletions, and half of those are 22q deletion. And then in babies who've got a cardiac plus something else, a third of these have got a single gene disorder. And if it's just cardiac and nothing else, 10%. And these are the various abnormalities on the genetic side. So it's in a world, in a sense, so important as we look at the cascade of investigating that we need to make a diagnosis as early as possible so that we shorten that cascade and give women the results early in the pregnancy. When we look at screening, this is the image I'm talking about of showing a 4-chamber and a 3-vessel tracheal view. And if you look in the ISUO guidelines, it's not showing it in 2D, like it shows the heart of the mid-trimester. It actually shows it with colour. And it's only in 2023 that colour became part of the ISUO guideline. All right, so what I would like to do is just to take you through a sort of a graphic tour of what the abnormalities are that you can't see. And the way I have it in my head, in a sense, is I have it in my head, abnormalities that I expect to see. These are sort of abnormalities that if somebody comes into me at 20 weeks and has a hypoplastic left heart or a hypoplastic right heart, and they say to me, Simon, why wasn't this picked up at 13 weeks? And I say, well, that's actually a very reasonable question. Why wasn't it? Because the detection rate is absolutely that this is an abnormality you should pick up early in the pregnancy. Nothing is always an obstetric ultrasound, so I'm just saying the majority. So if you go to work tomorrow morning and you look at this, and it's in my handbook, if you look at it, one of the key landmarks that you look at, and I'll talk about this more tomorrow, simplifying cardiac imaging, but the vessel sitting beside the vertebral body is the descending aorta, and therefore that's the left atrium, and there's no visible left ventricle in this baby who's 13 weeks of gestation. The detection rates in the published literature are on the order of 90–95%. And in a sense, it looks a little bit like what a hypoplastic heart looks at 20 weeks. And when you look at the 3-vessel tracheal view, instead of seeing that the trachea and SVC with laminar flow, you're actually seeing a big dilated pulmonary artery in blue, and then reversal of flow along the transverse arch. Exactly the same what a hypoplastic left heart looks at 20 weeks gestation. But you can make the diagnosis at 12 to 13 weeks, and it's not difficult, because when we saw 2 scans today, it was very straightforward with colour. We demonstrated inflow into 2 normal-sized ventricles. What about the other side? Again, the descending aorta, left atrium, left ventricle. So the problem here is in the right ventricle. The first thing I do is when I see a small right ventricle is I decide to increase my frequency, and I go from the C2 to 9. Descending aorta, therefore that's the right ventricle. I keep changing my transducer until I find out what's the best one. And as I do so, I end up using a transducer in this particular case that is firing at 15 megahertz. Now you look at that heart, and if I didn't tell you that this patient was 13 weeks, I know what you would say to me. You would say to me, Simon, that's a heart at 20 weeks of gestation. But it's not. It's a 13-week heart with a hypoplastic right cardiac ventricle. And that just shows you the power of frequency. And that's why we do a vaginal scan routinely, because we're firing the transducer at 9 megahertz, 5 to 9, or the 6 to 12 megahertz. And you can make a heart, in a sense, just look so much easier to detect these abnormalities. Descending aorta, left ventricle, and therefore it's the right ventricle. But when I look at this ventricle, there is flow inside the ventricle, but it's been filled through a VSD. So this is a fetus with a hypoplastic right heart with a ventricular septal defect. So it's a tricuspid atresia with VSD. And yes, we didn't really do it this morning with a fancy 4D stick volume analysis, and maybe we'll do it in the live scanning tomorrow. But this shows you just a three-dimensional perspective on that. Common arterial trunk is an abnormality I honestly believe we should pick in the first semester. And there are two types of common arterial trunk. So if you look at the four-chamber view of heart, you can have the common arterial trunk where it comes directly in the center of the heart, or you can have a common arterial trunk that comes predominantly out of the right ventricle and then splits. So when you look at this baby here at 13 weeks, this is the left ventricle and this is the right ventricle. Now you can see the trunk dividing. And this is a common arterial trunk arising out of the right ventricle, which is about 40%. And this one here is the trunk coming centrally. This is the interventricular septum, right ventricle, left ventricle. Very identifiable abnormality, strongly associated with genetic problems, and a diagnosis that's made at 13 weeks of gestation. This is an abnormality that's a really very straightforward diagnosis. I know many of you are familiar with it because you see the hugely dilated pulmonary artery with the bidirectional flow of absent pulmonary valve syndrome, a terrible condition. Many of these babies after birth do not survive. But you see a grossly dilated branch pulmonary arteries with bidirectional flow. But you know, you can actually pick them up in the first semester. They're slightly different though, in that they don't present with dilatation of the main pulmonary artery. But to look at the way the branch pulmonary arteries change from red to blue, from red to blue. That's telling you there's a bidirectional flow across the main pulmonary artery and the branch pulmonary arteries, but they're not dilated. That's absent pulmonary valve syndrome. And that's in the series that have all been reported today, detection rates of 100%. Again, it's the power of color. It strikes you straight away that you're seeing reverse flow in the pulmonary artery. So I'll just skip that one. And then we move on to this. So you do a four-chamber view of heart, and when you look in the center of the heart, you appreciate that there's loss of the AV valves on each side. In fact, there's a single common valve opening and closing in this heart in a fetus that's 12 weeks of gestation. This is your descending aorta. When you look at this, which is lying to the left of the spine, and any time that I see this, I always ask myself the question, where's the aorta? And then I ask the next question is, where's the stomach? Because quite frequently, this is associated with heterotaxies. So that's the importance of doing a split image, and why I do it in all the cardiac images. I start off with size, axis, rate, rhythm, and situs, showing the stomach on the left and the fourth chamber. When you get an AV canal defect, the first thing you should consider is heterotaxy, almost before thinking Down syndrome with an AV canal defect. So when I do a split image on this baby, the descending aorta is in fact sitting to the right of the spine, and I split and update, I should see a stomach here, but I'm actually seeing a stomach on the other side. So straight away I know in this baby I've got an AV canal defect, single common valve, and the stomach is on the opposite side. That to me is going to be a single gene disorder. We know with the heterotaxies, left atrial isomerism, right atrial isomerism, the vast majority of these are going to have a single gene ciliopathy. And therefore, that's going to accelerate your investigations. I'd almost say you're going to go straight to a wide exome sequencing following a first semester diagnosis of this, not waste your time waiting for the result of a chromosomal microarray. Another example, when you look at this baby here, this is the valve here, and there's complete loss of the center of the valve. And when you look at this baby, you can actually see the regurgitant jet when you look at 2D stick. You can confirm that by putting on color. So you go up to your 3-vessel tracheal view, and you look at your 3-vessel tracheal view, you can see there's forward flow in the main pulmonary artery and forward flow in the aorta. So you're going through your exercise of splitting the image, and then you go back to your fourth chamber, and then you see a central blue regurgitant jet. Remember, inflow is red, outflow is blue. When you look at this baby here, you see you're trying to get a four-chamber view of heart. This is your descending aorta, left atrium, left ventricle, but you're getting no fill. You should get equal flow into your ventricles. But when you look at this baby, you're not getting any flow across your right AV valve. And you go up to your 3-vessel tracheal view, all you're seeing is 2 vessels. You're seeing this vessel here and the superior vena cava. You are not seeing your V sign that you should be seeing on a 3-vessel tracheal view. You know it's abnormal. When you go on to the same patient transvaginally, again, you have difficulty visualizing the ventricular cavity on this side, and here you can see that you've got a single left ventricle. It's a complex cardiac abnormality. I won't go into it. But it becomes complex, especially when you go to look on the left ventricular outflow tract and you see both vessels coming out in parallel. So you're seeing a single ventricle that's been actually filled through a VSD, both vessels coming out of the right ventricle and both vessels coming out in parallel. Most of these really complex cardiac abnormalities are very detectable in the first trimester of pregnancy. Okay, let me put you to the test now. So you go to work tomorrow morning and you do a 4-chamber view of heart. Firstly, you see that the heart is central within the chest. Remember I said draw a line, and 2/3 of the chest should be in the left hemithorax and 1/3 should be in the right. Well, this heart is not that way. The heart is centrally positioned within the chest, and the descending aorta is not to the left of the spine, it's directly in front of the spine. So already I see that there are 2 problems. Then I see that there's fluid around the baby's lung. I see a 3rd problem. When I look at the 4-chamber view of the heart, if you look at it, it goes red, blue, red, blue, red, blue. You can see that? So it's not only in the pulmonary artery going red, blue, it's actually also going in the aorta. So seeing that scenario, and it almost looks like the baby's got a tachycardia because you're getting that rapid change in color. And you also see there's regurgitation across the AV valves. That's typical of polyvalvular dysplasia. No woman wants a diagnosis at 20 weeks of gestation. That is such a straightforward diagnosis using color Doppler technology, and that's why the detection rates are 100%. For me, that's one of the most striking abnormalities that everybody should make once you become familiar. In fact, we make the diagnosis of these abnormalities much earlier in pregnancy. This is at 10 weeks of gestation. When I look at the 3-vessel tracheal view, I see the main pulmonary artery and the aorta are changing from red to blue with equal volume of flow. So this is polyvalvular dysplasia. The aortic valves are dysplastic, pulmonary valves are dysplastic, the AV valves are dysplastic, and the baby's presenting at 10 weeks with an increased nuchal translucency. This patient does not need an NIPT. The patient needs a chorion biopsy, and then you need to look for the common trisomies. You can also pick up the rare abnormalities, and this is a baby with, you say to yourself, oh, I think it's got bilateral pleural effusions. If it has pleural effusions, the lungs would be here on each side. But the lungs are pushed to the back of the chest. It's a trap for young players. These are not bilateral pleural effusions. This is a baby with a large pericardial effusion. And when you look at the apex of the heart, you can see there's a tiny little bleb in the apex of the heart. When you look with color Doppler, you see the left cardiac ventricle is smaller when compared to the right, and there's flow into the diverticulum. And then this shows with stick technology the diverticulum arising from the left cardiac ventricle. Again, a very rare abnormality, but very detectable in the first trimester of pregnancy. You can use fancy stick technologies where you use transparency and silhouette, and you put your light source behind the heart. Once your light source is behind the heart, you can see the flow into the ventricles and the flow into the diverticulum without using any color whatsoever. And again, this is more sort of advanced fetal echo, but just shows you the power of what these machines can bring in the first trimester of pregnancy. I don't think there's any woman that wants a diagnosis of cardiac exstrophy at 20 weeks of gestation. I think women want to diagnose a cardiac exstrophy very early in the pregnancy. And one of the strongest clues you will see is that there are bilateral hydrothoraces. 90% with babies with cardiac exstrophy will have an intracardiac abnormality. When you look at these 2 clips of the same baby, it's actually very early in pregnancy, there's a single cardiac ventricle with 2 atria. And this is a baby with cardiac exstrophy at 8 weeks and 5 days by CRL. Okay, so they're the ones that you expect to, always see. What about the ones that are more challenging? You say, Simon, how good are you picking up transposition of the great artery in the first trimester? I'll say there's 2 very simple rules. The first rule is when you sweep up to the 3-vessel tracheal view, instead of seeing two vessels in an SVC, I should see the 3-vessel tracheal view with trachea and SVC. I'm actually only seeing 1 vessel. And that's the strongest clue. And the second is when I look at the vessel coming out of the right ventricle, it's going in the wrong direction. It should be sweeping in this direction and giving branch to the right pulmonary artery, the aorta, and the SVC. That reverse convexity is called the boomerang sign. And we reported that back in, whenever it was, 2019. In fact, we'd reported it on as a sign in the second trimester and then transposed it into the first trimester. I can make a certain diagnosis of transposition of the great arteries in the first trimester by using those two signs. You can go along for the parallel because it's much harder getting a left ventricular outflow tract in the first trimester when compared to the second trimester. But if you do get it, you can see the parallel vessels. But that's not reliable in the first trimester. It's reliable in the second trimester of pregnancy. Therefore, again, it comes back to the principle showing a 4-chamber view of heart and a 3-vessel tracheal view. You go to work tomorrow morning, descending aorta, left atrium, left ventricle. Now you tell me, do you think those ventricles are equal in size? You say, no, Simon, I think this left cardiac ventricle is smaller when compared to that cardiac ventricle. And I know it's the left. Then you go to your 3-vessel tracheal view, and there's your pulmonary artery, and then you've got a narrow transverse aorta. These are all the signs that you use to make a diagnosis of coarctation in the second trimester. They're all visible and there in the first trimester of pregnancy. You do a scan tomorrow morning, and the first thing you do is you see that the descending aorta lies to the left of the spine. You're happy. But when you look at the apex of the heart, you realize that the apex of the heart is at 9 o'clock or at 10 o'clock. And this is the spine. So this heart is left axis deviation. That's a very powerful marker of outflow tract anomalies, common arterial trunk, double outlined right ventricle with the subaortic VSD, or the most common of all is tetralogy of Fallot. And that's how our sonographers pick it up. They pick it up because they see axis deviation. And then they rotate to a 5-chamber view and they see the aortic override. If they fail to miss that there's axis deviation, if they fail to miss there's aortic override, they then pick it up by realizing instead of seeing a V sign, they see a Y sign because there's proximal insertion of the pulmonary artery into the aorta, under the undersurface of the aorta. That's a super sign. When you look in the 3-vessel tracheal view, you see a Y in all of these babies, again, 4 chambers, going up to a 3-vessel tracheal view, a narrowed pulmonary artery with a dilated aorta, but that Y configuration. You may be lucky finding a left ventricular outflow tract where you see the aortic override, or in this baby here, the aortic override on a slightly oblique view of a left ventricular outflow tract. But as I say, LVOT views are challenging. In the more recent technologies, you can use the graphics flow. So here's the aorta sitting astride the interventricular septum. And this one here just showing graphics flow. The graphics is just showing tiny little vectors of flow of red blood corpuscles. But you can see that dilated aorta sitting astride your right ventricle and your left ventricle here. A very detectable abnormality in the first trimester of pregnancy. As you sweep in this baby, looking at a 4-chamber view of heart, so this is the right ventricle, and you see both vessels come out in parallel. These are the typical appearances of a double outlet right ventricle. Again, strikes you straight away as you go from a 4-chamber to a 3-vessel tracheal view that the vessels don't cross. You know that they should cross, but as you sweep to the 3-vessel, you see these two things coming out directly out of the ventricle in parallel. An unmistakable diagnosis. In this baby, you see that the right atrium is dilated, and when you look in color Doppler, you see the regurgitant jet is rising deep from inside the right ventricle. Epstein's anomaly. Again, remember the association of Epstein's anomaly with trisomy 21. We offer chorion biopsy. They may not have an increased nuchal translucency. And for this baby here, you see that the actual AV valve is not displaced, but it's like a skipping rope. Just have a look at that right AV valve. It's bobbling up and down. And when you put on color Doppler, you see the regurgent jet originating deep in here and with dilatation of the right atrium. This is a baby with tricuspid valve dysplasia. This is a baby with Epstein's anomaly. And when you look at stick volume analysis on this, you can see the severe regurgent jet, and you can also appreciate it on a stick volume image here without any color whatsoever when you see the disturbance of flow with dilatation of the right atrium. When you look at right aortic arch, again, a very detectable abnormality in the first trimester of pregnancy because in here is your trachea, and instead of having this should be on this side like so as a V sign, and instead you're ending up with a U sign in the trachea in the center. Again, it strikes you straight away because the 3-vessel tracheal view on color is abnormal. In a baby with a double aortic arch, you've got that typical Z configuration instead of a V configuration. You can see the exact same Z configuration of a double aortic arch in the first trimester. Important because these babies are associated with, have a risk of tracheal atresia. I'll finish up with the last group, which is the group you never detect. Well, I say never, because when you look at this four-chamber view of heart, you can see the baby has got a muscular ventricular septal defect. I know it's the only abnormality. I know it's got a low association with aneuploidy. If the rest of the heart's normal, I would not offer a chorion biopsy. But remember, large muscular ventricular septal defects do require surgical closure, so don't forget about that. And then there's a scenario of looking for critical aortic stenosis, and this is a baby who has a big dilated left ventricle, fibroelastosis with a poorly contractile ventricle. So you say, I get a phone call saying, Simon, this baby's 18 weeks of gestation, she's got critical aortic stenosis, and they say, well, where did she have her scan done? She had her scan done with you, Simon, and that's when you have a panic attack, and you say, well, really? And then you go back and you look at your images, and then you go back and you look at your images from the scan at 12 weeks and 6 days, and you see a normal four-chamber view of heart, normal left ventricle, and a normal three-vessel tracheal view. So between 12 weeks and 6 days of gestation, between 17 weeks, I said over that 5 weeks time, this baby developed a hypoplastic left heart, and that's a classic presentation of critical aortic stenosis. Again, at 20 weeks of gestation, critical aortic stenosis, and a normal four-chamber view of heart earlier at 13 weeks. So these are abnormalities that evolve, and I do understand that there are limitations of these abnormalities at this stage in pregnancy. So in summary, what difference does this talk make to you when you go to work tomorrow morning? I think the first thing is that I would encourage that if you haven't done it before, just do 100 scans and split an image and demonstrate a four-chamber view of heart, the interventricular septum, and with colour, and show that the ventricles are equal in size, and then do a three-vessel tracheal view with colour updated. And if you do that, you know the baby is very unlikely to have a major congenital heart defect. If it doesn't fit with that, then you know you've picked the needle out of the haystack. And if you're interested in maternal-fetal medicine, then you jump to the next stage of offering invasive genetic testing and moving forward. But remember the power of colour in the first trimester of pregnancy. Thanks very much for your attention. And just one last word, sorry Kareem, one last word to mention to you is that we are running the ISUOG Fetal Cardiology Conference. We last ran this in Dublin 2 years ago. And that was, I have to say, our most successful meeting to date. We had over 700 registrants to it, and I'd love that to be another successful meeting, and hope we can get a Middle Eastern contingent visiting us in Seville. It'd be very exciting. For those of you who like flamenco dancing, come to Seville. Or if you can't join us in person, please join us online for the 22nd, 23rd of May. Thank you very much.